It's funny to talk about self-care because, of course, the number one thing I would say is you should get 8 hours of sleep a night. How many of you got that last night? 3 people? 4? I got 9 hours personally. I don't know if that makes anyone angry. We'll talk more about that in a minute, but the reality, of course, when we do the work that most of you do, the basics are sometimes, although we know what we're supposed to do, they're not necessarily accessible to us. So before I get started, and I may, I have slides and there's stuff I want to talk to you about, and at the end, I usually have more slides than time. I promise you I'm going to give you all the juicy stuff. I'm going to tell you what's evidence-based and what is evidence-informed, because in fact the field of compassion fatigue and burnout, although we should know more, because we've been talking about burnout since 1983, there are not a lot of randomized controlled trials to kind of talk about this. One of the only RCT I know is a study that demonstrated that mindfulness dramatically reduces compassion fatigue. That's an RCT. But there's a lot of stuff I'm going to present to you that is actually much more evidence-informed. So I know people like to know where the research is from. I'm going to embed what I'm talking about as much as possible in research. But what we also did, because there weren't a lot of studies out there, is we created a think tank, 2015. So 2015 was a blessed year. You probably don't know this. I was probably the only person excited about this. It was the 25th anniversary of the publication of the first ever paper on secondary trauma and compassion fatigue. And I contacted the author of the paper and the subsequent book, and I said to him, Dr. Figley, what are you doing to celebrate this momentous occasion? And he said to me, stop emailing me, you little freak. No, he didn't say that. That's not true. He very graciously wrote the introduction to my book, which is called the Compassion Fatigue Workbook. But he said, you know what? I'm ready for a succession plan. I want to wind down. You go for it. And I said, great. I want to have a think tank, which now is called the Secondary Traumatic Stress Consortium. And I want to meet every year with people who do policy, clinical work, research on things related to provider exhaustion or wellness. And I want to create best practice recommendations. Now, we had no money. I don't know if you know what it's like to get funding when you're a disparate group across North America. And we thought, how do we get together? And we found funding the very first year from the weirdest possible place. How many of you know Mariska Hargitay? Olivia Benson in Law and Order? Dun dun. Law and Order SVU, yeah? So Olivia Benson, or Mariska Hargitay, as many of you know, it's a show that I don't recommend you watch at night after your day of work, because I find it pretty traumatic, but it's a show pretty much about sexual violence and crime. She started getting thousands of letters from victims of sexual violence saying, my rape kit was never processed, I never had my day in court, I need support. And Mariska Hargitay created the Joyful Heart Foundation, which is a charitable organization that advocates for sexual violence. She successfully advocated for Memphis and Detroit to process a rape kit backlog. She really is an advocate. So she heard about what we were doing, and she gave us seed money with no strings attached to start the Secondary Traumatic Stress Consortium. Incredible, right? It's the only thing I've ever done that my daughter, who's 21, thinks is cool. And so since then we meet. The Secondary Traumatic Stress Think Tank meets 4 times a year. We are currently creating best practice recommendation consensus-based guidelines. And so what I want to offer you today is embedded in the knowledge and the learning that we have. So that's my academic side. If you want more about that, I'll give you our email at the end, and I'm happy to provide you any of the paper or references you want. The last thing I'll say before I dive into this is, obviously I'm French. Is there a Frencher name than this? Can't really get any Frencher. It basically means I am French, right? So I was born in northern Quebec. I was born in the high Arctic. I lived in Pavornituk, Kuujjuaq, and Kuujjuaqapik, and Inuktitut was my first language. My parents were teachers up there, and then moved to Montreal, and now I've lived in Kingston, Ontario for 25 years. And I was the crisis counselor at Queen's University. Any of you went to Queen's? I was the crisis counselor at Queen's for 7 years, and I'll embed some stories about that too. So that's a bit about me. Because I'm French, I talk fast. And I get very passionate about this topic, so I'll try to be zen today. I'm going to start with a case story and an example of something that many of you will remember, and it is the story of Brian Sinclair. How many of you remember this story of this Aboriginal patient who died in a Winnipeg emergency ward after spending 34 hours in the ER? How many of you remember this story? Right? And you're going to remember also that when it was covered in the news, they always referred to him as, the headline was, "Homeless Aboriginal Man Dies in ER." Do you know that he wasn't homeless, actually? I'm going to park that for a second. He actually wasn't homeless. He had a home. He was a residential school survivor, and as you can imagine, he had turned to substance use to cope with that. And he was a huffer, so he was someone who had sniffed solvents, a variety of cases, and he was now sober, but because of that, he had neurological damage, and so he had slurred speech, which made it seem like and look like he was under the influence. Do we have any ER folks in the room? Right? And so he shows up. Oh, and the last piece that's important to say is that because it's Winnipeg and the winters are cold, he had lost his lower limbs to exposure because at some point when he was under the influence, he had slept outside and he was a double amputee. So Brian St. Clair comes to emerge that day. He had a catheter, and he had some issues and diabetes. He shows up in ER that day, and no one ever triages him or looks after him. And in fact, by the time he was deceased, he had been deceased for 12 hours. And the reason that it was discovered that he was no longer alive was a fellow patient who went to the security guard, and I said, "I think that guy's dead." Now, there was, of course, an inquest afterwards, which I read cover to cover. And the reason I'm telling you this story is probably not what you're expecting or what you think. What I liked about this inquest is instead of putting someone's head on a spike, instead of blaming the 2 triage nurses and the 2 security guards who missed it, this had a very different story and perspective. Would you agree that there are a lot of times in the work that you do when someone messes up, something goes wrong, someone pays? And what they recognize instead is that this was a systemic problem, and they made 200 recommendations for changes in the hospital. So the first part was about racial profiling. He had been profiled as a homeless man, and the security guard said, "Look, I thought he was just sleeping off his drunk outside of the cold, so he was invisible." Now, can you imagine how many Brian St. Clairs, maybe even Brian St. Clair, showed up in that emerge on a typical day, week, or month in Winnipeg? Lots. The other thing that they realized is that there were some structural issues. I do a lot of law enforcement talks, and they're like, "Whoa, it's a floor plan. I'm going to talk about where the crime occurred." But there's something really interesting about this. So it's a little hard for you to see here. But what it turned out is that the structural layout of this temporary ER, have you ever worked somewhere that was temporary and 25 years later was still the same? The building I worked in at Queen's University Student Health Counseling Service was used before we moved in for research involving radioactive isotopes in dogs. And then we moved in, right? Temporarily. We're going to get a new building. I haven't worked there in 10 years. I have like this affiliation. We're going to get a new building 25 years later. So what happened in this emerge was that Brian St. Clair in his wheelchair was tucked away in a corner. He was outside of the field of vision of the triage nurse, who was very, very busy, and also tucked away from the field of vision of the security guard. And also Brian was invisible. So the first recommendation was actually a structural change. Let's change the layout of the ER. They made 200 other recommendations. I'll only highlight 2 for you. The second thing that happened is, anybody know or remember what Brian St. Clair died of? That's correct. Sepsis due to a UTI. That's it. He had a UTI, and it went septic. You can read the coroner's report. It's actually really interesting if you're in the field of medicine. So it was absolutely a preventable death. And the final recommendation they made is they concluded that all of the ER staff suffered from incredible compassion fatigue and burnout. And Brian was invisible because they had seen thousands of Brians, and they were done, right? And so I like that, because finally we're making productive and constructive recommendations that actually look at the systemic issues of a hospital, not just individual recommendations. Now, any of you have ever been given a stress ball, right? And you got it and you're like, that fixes everything. I feel so much better, And so when I give presentations in hospitals, which I do a lot, I have a lot of physicians and nurses come to me and allied health professionals, and they say, don't tell me to take better care of myself. I know exactly how to do that. What I want are structural changes. I want more control over my schedule. I want more referral resources. The problem is with the system, the structure, the Ministry of Magic, if you're a Harry Potter fan. The truth is that it's not just about basic wellness, because most of us know how to do it, even though the research shows that we don't follow through on many of those things. So as I mentioned before, this is a secondary traumatic stress consortium. At the end, I'll present to you some research that we've created and reports we've produced. Everything I'm going to mention today are free resources that are available for everyone. We work with a very wide range of groups. And what started interesting me about that is that we don't need to modify our talks very much, whether we're speaking to law enforcement, paramedics, physicians, nurses, social workers, or educational assistants in schools. And that seems kind of odd to me. But then we started realizing, if you think about it, for those of you who actually speak to patients, they're not unconscious, you know, anesthesiologists, but the rest of you, like who speak to people and their families, would you agree that the most draining cases are probably people who are also a drain, without blaming them, on every other part of the system? Right? Our frequent flyers, our hard to treat, our non-compliant, and all the other words we have for them. So we started realizing that we are all serving the same people, sometimes at exactly the same time in their lives, sometimes at different times in their lives. I was just in Denver last week. I was working with a drug court there, and some of them were doing juvenile drug court, and the other ones were doing adult drug court. They're the same people, just at a different developmental stage. So I'm going to give you 2 disclaimers today. I wrote a paper in 2015 to celebrate the blessed anniversary of the 25th anniversary, and it is called Beyond Kale and Pedicures. And I wrote it by interviewing very successful workplaces, including Vanderbilt University Hospital. I don't know if any of you have been there or are from there. Vanderbilt is considered to be one of the healthiest hospitals to work in America, other obviously than the Mayo Clinic. If you saw the documentary, anybody saw the Mayo Clinic documentary by Ken Burns? Lots of trumpets and classical music. It's pretty lyrical and allegorical, but it's considered to be a very healthy organization to work in. And I'm always interested in looking under the hood, right? When something's working well, I want to know why. And one of the things that happened at Vanderbilt, and it's not perfect, I'm sure if you meet people from there, they're like, oh yeah, let me tell you the 12 ways in which I'm pissed off about my... Of course, right? Every workplace has its challenges, but what Vanderbilt realized, and what mattered, is their leader was a former ICU physician. So she knows what it's like to do this work. Secondly, she realized that what mattered the most to have a healthy and happy hospital was to attract and retain happy physicians. It turns out that happy physicians create happy workplaces. Happy physicians, happy nurses. Happy nurses, happy everyone. Because no one wants to mess with an angry nurse, right? Nurses in the room, you know what I'm talking about. So this is actually a paper that I published, and we were looking at all sorts of happy and healthy workplaces, and I wanted to know what were the key elements. But what happened as a result of that is some places decided that what I was saying was I didn't believe in self-care. I was fired from a job, well, you'll see why later, because I offend people every day, it's awesome. I'm no longer invited to Salt Lake City, Utah. I did something bad there. Ohio, I called Trump a sociopath in front of law enforcement. I know! Right? I had to apologize at the break. Yeah, it was great. And I was fired from an engagement where they said, it was in the West Coast, you'll understand, it was like very crunchy granola, and they were like, we're offended because we believe, you know, in wellness and self-care, and we feel like you've just thrown out the baby with the bathwater. And I said, well, did you read the paper? And they said, no. I was like, I believe in self-care more than anyone. I do get 9 hours of sleep a night. I exercise every day, because if I don't, I have generalized anxiety disorder. But if I exercise every day, I feel amazing. I believe in self-care, but it's not quite the magic bullet we had all hoped it would be. And I believe that there are systemic changes that need to happen. So that's my first disclaimer. I believe in self-care. The second thing that happened is I started, so you can probably tell already, I'm I'm an oppositional person. I was a kid that was moved in the classroom for talking from one desk to another, and every time I'd be like, a new friend, you know. So I do what I want. I'm self-employed. I shoot from the hip. I say what I think. And I started getting really not okay with this thing that was happening. So this was a long time ago. I was, as I mentioned, the crisis counselor at Queen's University. And I don't know what it's like in Oakville, but we have very limited mental health referral resources in our community. If you have an eating disorder, we will probably send you somewhere else. We call it geographic relocation therapy, where we gift patients to other communities. I'm sure you've done that too. And I started getting really bothered by something that I witnessed, and here it is. And I want you to think about whether this has ever happened to you and adjust it to the reality of the work that you do. It's Friday night, it's probably a full moon, and it's 4:45. I finish at 5, and in those days I had 2 little kids in daycare. And if any of you have had kids in daycare, you know that when the daycare closes, I don't know what they do. They put them out with the recycling in their snow pants. Like, you cannot miss the deadline. So it's 4:45, and a patient comes to see me, and he is severely suicidal. And I'm a crisis counselor, so I'm not being a drama queen. He's got the means, the ways, the methods, and so on. But I only have 15 minutes. So what do you think happens? What do you think I do, given that I only have 15 minutes to deal with him? I have him formed. And I'm not saying that involuntary committal is ever, sometimes it's exactly what needs to happen. And so I have him formed, and off he goes to the psychiatric ward. And what didn't sit well with me is I asked myself on my way home, if it was Monday morning and I had all the time in the world, would I have him formed? And the answer was no. The answer wasn't the severity of his risk. The answer was my capacity was not the same. And I'm not saying it was a wrong decision. I think it was the best decision in that moment. But that started really bothering me, that I was being more interventionistic, or throwing a label that can stick to someone for years, or prescribing a medication because I needed them to get out of my office. And we know that, right? Gomer, GOMO. And sometimes we do it because our capacity is limited. And that's what started this journey of looking at, what is this thing? The final thing that started this journey is I started seeing some wonderful healthcare professionals and some terrible ones. And I'm sure you've had this experience yourself as a consumer. Have you ever been in an intervention or a situation where you thought, what an asshole? And you thought to yourself, surely to goodness you did not go into healthcare because you hated other people. Something happened along the way, and I basically wanted to enhance capacity so we can do a good job so that our patients are well treated as well. Now, there was a study some of you may be familiar with that came out of Israel, and they found that judges were far more likely to grant you parole after lunch than before lunch. They just needed a sandwich. So some of the questions that we're hearing right now, and you know, there's quite a mix of age groups, because some of you look super old in this room. I can tell, like, definitely have some boomers in here. But some of you have seen multi-generational friction in the workplace. Medical residents are different, aren't they, than they were 10, 20, 15 years ago? And that's becoming a source of interest to me, to look at multi-generational teams. So is self-care enough? Well, we're very lucky because we had research done right here in Toronto. There was a study done by Cheryl Rieger and Ted Bobber. Some of you may know them. And the study asked the following question. They said, hey, does self-care work? And when I read this paper, I was quite nervous at first because I talk about self-care all the time. And here is what they found. So first of all, they found that believing in self-care does not actually translate into actualization. How many of you own a juicer in this room? Raise your hand. How many of you own a juicer? Nice and proud. Keep your hands up. How many of you use it regularly? One person, our psychiatrist. Good for you. And our wellness expert. Right. So, friends, owning a juicer that sits on top of your fridge does not translate into any more self-care than not owning one. Does that make sense? All right. So what was also discovered, so believing in it did not actually mean that we did it any more often. And it turned out that self-care on its own did not reduce people's rates of secondary trauma. So I read this paper, and I immediately called Ted, the author of the paper, and I was like, oh shit, right? Because I had been telling everyone to take care of themselves for 15 years. It turns out that on its own, it's not enough. And there's one more problem. Workplaces got very passionate about self-care. You see why people think I don't believe in it, but stay with me. And workplaces started using it as a way to blame our service providers. So we'd be like, well, if you had better work-life balance, you know. Or there was doublespeak of places that would say, you know, we believe in work-life balance. Have that on my desk by 4. Right? I'm not blaming anyone. Luckily, I know nothing about this institution. I do that on purpose. I don't want to know your business. It's probably the same as everywhere else, right? And so basically, have you ever received an email at 2 o'clock in the morning from a leader? As a leader, have you ever sent an email at 2 o'clock in the morning? No blame, because you're like, well, I have short-term memory issues. I'll send it right now. But what message are we sending to our staff if we are not actually doing what we believe in? The final piece I'll tell you about that is I was working with a hospital somewhere else in the province, and they wanted to have a campaign, and the campaign was they were supposed to wear buttons. It said, we deliver compassionate care, and the nurses said, we're not wearing the effing button. Right? Because it wasn't true. So if you're in a leadership role, what I want to invite you to think about also is it is great to survey our staff and see how they feel. Our employment engagement surveys are great, only if you follow through. If you do engagement surveys and nothing changes, you are squandering the goodwill of your staff, I promise you. And that's what staff have told us as well. So yeah, sadly it turns out that kale and pedicures is not the answer to all of life mysteries, which would have been amazing. But it turns out we have enough data to know that's not enough. Here's my second disclaimer. Enough with the word burnout as an umbrella term that is supposed to represent everything. Let me tell you why using burnout exclusively is a problem. Do you know that in physicians, you've all heard the word burnout, physician burnout, and there's research about it, right? You all know about that? Do you know that every profession have a different word, and we use different scales and assessment tools? So some groups are using vicarious trauma. That's what they research. Some people are studying secondary trauma. Other people, compassion strain, other compassion fatigue. Do you know what it's like as a scholar when you're trying to do a lit review? When everyone's using a different term? And so we have a different perspective on what burnout is. And to give it away real quick, it turns out that burnout can happen in any occupation. It has nothing to do specifically with trauma or exposure to pain and suffering. Think about it. Any of you had a part-time job back in high school that would win the award of lousiest part-time job in this room? Anybody? I was in Alberta recently. Someone worked in a chicken gutting factory. I met someone else who cleaned shower stalls at a truck stop. Would that win? Can you agree that you could have burnout in any occupation? Any of you have friends still? Yeah? How about civilian friends? Any of you have friends who are civilians, like don't work in healthcare at all? Yeah? Good for you. Accounting, IT, advertising, finance, yeah? Do you think they could have burnout? Absolutely. Burnout has to do with your working conditions, your hours, your pay, your rewards, your recognition. It is a misuse to use the word burnout exclusively for what's going on for all of us. The more we understand what's going on for all of us, the more we can actually act on it. So I'll present to you our model in a minute. Many of you probably saw the CMA National Physician Survey that came out in October. I love what Canadian data comes out because what happens often is when I present in Canada, we mostly have US data and they're like, well, this isn't about us, this is about you. Like actually, right? And some of you found and saw what was found. So there's a lot, I won't spend a lot of time on it, but what was really interesting is it was found that younger physicians have actually higher rates of burnout than older physicians, right? So this isn't actually all about wear and tear. Because if burnout was about wear and tear, what you think is basically you're going to go into medicine and after 20 years you're going to expire. That's not what's been found. There are some really interesting waves of attrition. And one of the first wave of attrition is at the beginning. And I mean, any physicians in the room, residency is extremely grueling. So are the CARMs, right? Oh, that's such a good time when everyone's waiting, you know. But the reality is that we found these spikes. But the higher rates of burnout are earlier in the career, and we think that's coinciding sometimes with life circumstances, right? Big financial burden, sometimes starting a family, doing the double shift of parenting and all of that, but also lack of experience. So those of you who have a short attention span, and I've already been talking, and you're like, here's the giveaway. Confidence and competence are the two most protective factors against burnout. Because some of you have been around for a while, would you agree that there are a lot of things that used to be quite stressful to you where now you're like, I know exactly how to deal with this? Confidence and competence. And we don't have that when we're starting out. Well, if we do, that's concerning. So my son last year had, it turned out to be mono, but he went into the urgent care, pediatric urgent care. And have you ever had a cowboy resident? You know the ones like they're way overconfident? He looks in my son's throat, he goes, yeah, we're gonna have to lance his tonsils. And I was like, yeah, I think I'd like a second opinion. And so then our real pediatrician comes, and I don't know if any of you know Kingston folks, her name is Dr. Kira Luda. She is the most wonderful, terrifying physician, advocate for patients. She's amazing. And she, of course, realizes he has mono, and she looks at me and she goes, tell me the name of the resident. I'm going to lance his tonsils. He was overconfident and definitely not competent. Hospital-based physicians have increased odds of lower emotional well-being compared to people in the community, lower social well-being, and lower psychological well-being. That's the data from this year. Over 80% of you said that you were aware of physician health programs, but only 15% of them had accessed it. And the barriers we're hearing again, this is not serious enough, but also about stigma. So can I put this out right now to you who are physicians? You know that the physician wellness program that's offered by the OMA is confidential. Like, I swear to you, I just talked to Ted, who is actually the person who runs it. No one is going to be reported. There's a myth out there that this is not a confidential service. It is 100% a confidential service, but we hear this all the time. So I won't spend too much time on prevalence, but basically our biggest obstacle, as I mentioned already, is that we don't agree on nomenclature. So if we don't agree on nomenclature, I can't do a survey because we're all using different terms and different methods and tools. Secondary trauma and clinicians, in trauma clinicians, between 15% and 50%, depends on where you work, how much exposure, and all sorts of other factors, which I'll discuss later. Medical residents have very high rates of stress effect. Many of you know Tate Shanafelt, who was at the Mayo Clinic until recently, who is the burnout expert in physicians, and he's done some really interesting studies. He had a paper a few years ago that found that the rate of suicidal ideation in surgeons was extremely high. So at least a quarter of the physicians surveyed had had suicidal thoughts, and very few of them said that they were willing to get help because they were afraid of stigma. And many of them, 33% of the surgeons he surveyed, talked about worrying about having left something inside a patient. I'm sure that's absolutely reasonable, but who do we talk about that with? Nursing staff, do we have nurses in the room? Hi. So what percentage of nurses have been physically assaulted on the job? 100%. 100%, right? And as you know, we now have the presumptive legislation for PTSD, but nurses had to fight for that. Guys, I was at the Ministry of Labor's office 2 or 3 years ago when it was presumptive legislation for PTSD was released for first responders. And 2 terrifying women from the Nursing Association stormed the room, grabbed the microphone from the Minister Flynn of Labor, and said, "Shame on you." Have you ever seen a really, really old, really angry nurse advocate? She won. No, but in fact, we don't recognize that there's actually very high rates of physical and verbal abuse in the workplace, and that's something we're finally discussing. We see the same, by the way, and I'll just move on after this, but we're having a real issue with turnover or retention. Child protection workers, on average, are lasting 2 years and then they're leaving. And teachers. Educational assistants in this province. So you know what EAs are? They come and help kids who have special needs in the classroom. Do you know how many of them have been on stress leave for PTSD and concussions for being assaulted by the kids? Many, many. I can't even go into the details because there's something going on right now there, but there is a huge issue there too. A lot of allied health professionals have issues around this. There isn't as much research about OTs and PTs and so on, but we know it's there. So let me present a new nomenclature for you. And if it's too early in the morning and your brain's foggy, I want to invite you to look at this and think about, you don't have to disclose this to anybody, but where would you put yourself right now? You ready for this? So as I present this, you could fill this out in green, yellow, or red in your mind's eye and think about which are the most salient issues for you. Because here's the thing. The more you know what's happening, the more you can decide what to do. And I'll give you a case example in a minute. So number one, your personal vulnerabilities. Yogi Berra said years ago, we're all bozos on the same bus. What is the difference between you and the people you serve? Yeah, often luck. Warren Buffett said he won the ovarian lottery. Right? What's different between us and the people we serve, quite frankly, sometimes is nothing. I was at a victim service conference in Banff last year. So these are victim support workers. And the woman at the end said to me, "May you never need our services." And then I ended up needing their services. I won't slime you with the details. Everyone is healthy. Arrests have been made. But my son is at McMaster University. And on his first day on campus, him and his friend, you probably heard about it on the news, were leaving a street party, and his friend was stabbed in the spine. Some of you heard about this, right? It happened September 6th this year. And he survived. It's a miracle. It's a very long story. He's back at school. But from a moment, I went from being someone who talks about this to being someone who needed these services. Can we agree that the weeks following that, I was not necessarily in the best state? Right? And what's also interesting is, those of you who do a lot of critical care, would you agree that when something stressful happens in your personal life, you become extremely calm? I went down to hypoarousal. I became the calmest. Everyone else is freaking out. I'm on the computer looking up the name of the detective because I didn't like how he handled the case. And my son's like, "Mom, I know you found his address, his salary, his phone number, his supervisor's name. I don't need you to case manage this." And I was like, okay. So what's going on in your life? You have other caregiver needs? Do you have a spouse with an illness, a child with issues? Like, that's our stuff. Do you have a history of depression? We never talk about that. You know, substance use. So what's going on in your life? Number two, traumatic grief and loss in the workplace. That could refer to a patient dying prematurely or in a complicated way. What about a colleague? Do we ever have time for that? A colleague dies. A colleague is marched out by security and you never see them again. I hope you've never been through that. I have, right? You are blended, local, anyone who's been around for a while, re-centralized, LINs, no LINs, Community Care Access Center, no more. You know, we're part of all these changes, new computer system, all these changes. Direct exposure, which I mentioned before. You are assaulted, threatened, right, at risk. You heard at KGH Hospital a couple of months ago, we had 2 prison guards accompanying a patient in the ER, and he grabbed hold of his gun, one of the guards' guns. Did you hear about that? And shot a patient in the foot. Thankfully, nothing worse. That's direct trauma. And how much of that do we have? Secondary trauma refers to ways in which your view of the world is altered by the stories that you hear. And we'll talk more about that in a minute, because I think that's really salient for many of us. Maybe we become hypervigilant about our children's safety if you have kids. We know too much. I have a friend who has never let her kids eat hard candies because they saw someone choke, right? I was at the coroner's office a few months ago, and as you know, it's been a tough year for the coroner's office and for Toronto. We had the van attack, we had 2 serial killers. Well, they're processing all that, right? And what was really interesting at the coroner's office, by the way, is one of the women there who used to be an ICU nurse, you know what she said to me? She said, "We treat the deceased with more respect than we treat the living." She said, "You will never see at the coroner's office disrespectful behavior towards the remains, ever." She said, "It's a really, actually healthy workplace." And then another person had their arms crossed. It's great when I walk into a room, everyone's got their arms crossed. My favorite are Crown prosecutors. They're the best. Very hostile, you know. And one of them said to me, "I don't know why we're doing this topic. It's not relevant to us." And I said, "Great, let me ask you a question." I said, "Do you have kids?" She goes, "Yes, why?" I said, are your kids ever allowed to go to a friend's house that has a swimming pool? She's like, are you crazy? Of course not. That's secondary trauma, right? Your view of the world has been altered by what you've seen, and that's not good or bad, but we need to recognize that it is. Compassion fatigue, the erosion of care. You've seen thousands of cases with the same stuff, and at some point you could be making your grocery list while you're managing it. Do you know how many first-year students I saw at Queen's University who were in a long-term relationship with someone who was going somewhere else? It was a long-distance relationship. Let's call them Miffy and Chip. Miffy is at Queen's. Chip is at Police Foundation College in Aurelia, my favorite joke city, I don't know why. And they're in love, and they're going to make it work. What is the first-year breakup rate in long-distance relationships in undergrad? Anybody know? 95%. In fact, it's got a name. It's called the turkey dump. Because 6 weeks later, when you come home for Thanksgiving. So do you think I'm listening? You get it? I have lots of trauma stories I could tell you, but instead I thought I'd tell you this one. Do you think I'm listening to Miffy, or I'm just booking her for the week after Thanksgiving? Right? Compassion fatigue is an erosion of our compassion because at some point we've heard and seen so many things. And I'll give you another quick example in a minute. Systems failure. This is a really good one, and I think it's the one that leads to the highest rate of stress and frustration in a hospital. There's a scientific term for this. I'll tell you what it is. I'm sure you'll recognize it. It's called the bullshit. Have you ever experienced that in your job, where rules, regulations, and procedures conflict with what you believe is ethical and right, and your reaction is, this is bullshit? That's what I'm hearing the most in the hospital. Not necessarily the trauma is hard on me, because a lot of you have done a lot of it, and I'm pretty desensitized to that. Not necessarily my personal life is a mess, and that's having an impact, or I've been assaulted by a patient, or I feel nothing. What I'm hearing a lot in hospitals is people are saying, I am angry all the time. And that's what we need to figure out, and I'll have some strategies for that in a minute. And the final one, yes, is burnout. Your working conditions, who you report to. Did you know that what matters the most is not where you work, but who you immediately report to is what matters the most? Listen, Kingston is the prison capital of Canada. You know that, right? We are recession-proof. We will never stop putting people in jail. Yeah. In the prison system, some of the prison correctional workers I work with are actually very well. And what they always said is who they reported to mattered more than if they were working at Collins Bay or Kingston Pen. So this becomes a map for you to figure out what's going on. What do you need attention for? So I'll give you a case example before we move on. So I worked at Queen's University for 7 years. I had a great boss who now works for me because he retired and I hired him. But we had very limited resources, very, very limited. We had nowhere to send people. We also played ping pong with the ER. Have you ever had this where we're both supposed to serve the same groups, but we have limited resources, so we're fighting with each other? So I would send someone to emerge. They would discharge him to my care with no treatment. I'd send them back. You know, we had to have a meeting at some point. And they were like, oh, Queen's students, they're rich. They have resources. I'm like, first of all, not everyone who goes to Queen's is rich. Secondly, did you know the rich people are just as fucked up as poor people? Come on, isn't it the truth? I have seen the level of dysfunction and neglect in my kids of privilege there was incredible. So let me tell you why I quit. After 7 years, I quit, and I went to my boss. I gave him 4 months' notice because I'm ultra responsible. And he said, you can't leave, you're my best. You come in early, you work through lunch, you finish late, which, by the way, is called the zealot phase. The zealot phase is when you believe that you are so indispensable that no one can do your job and you work harder, and it's right before crashing. It's called the zealot phase. And at that point, I had 2 little kids. I volunteered at the Kingston Penitentiary at night because that's a great hobby when you're a crisis worker. And one night, it was a Tuesday, my kids are like 3 and 5 years old. I come home, and I don't know what your warning signs are, but when I'm close to the red zone, I am irritable and I become like a drill sergeant. I just want to case manage everything. I have lists and shit, you know what I mean? So I come home and I say to my husband, I said, can you process the children and I'll make the lunches for the week? And he goes, He goes, excuse me? I said, pajama time, bath time, story time, let's do this. And I start doing all these things, and he says to me, you better sit down. And I'm like, what? And he goes, we are not processing the children. And I said, you know what I mean? And he goes, actually, I don't. And he said, look at this child. In 12 years, she will be gone. And you're sleepwalking through her life. And yes, you are great, and you have a cape and stuff, and you save the world. He said, this is not a sustainable way for us to do this. And he was right. But the reason I'm telling you this story is what happened next, which is contrary to what most people watching from the outside believed. So I go to my boss, I quit, and then I go work full-time for the Canadian Forces Member Assistance Program. So that's the EAP for the military. And I start a full trauma practice. All my soldiers are coming back from Afghanistan and Rwanda and Somalia, right? And a lot of people were like, wait a minute, frying pan, fire? Not at all. I love trauma work. It was the best job I had, and I did it for 10 years. But let me tell you what was different about my new job. First of all, I had complete control over my schedule. So I didn't see all my 4 most traumatized soldiers Friday afternoon on a full moon. I could interrupt my day and go to my little poopsie school recital and all that stuff that we do. Take my mom for her MRI, go to the gym. I worked hard, but I worked smart, so I had control over my schedule. Secondly, I realized I did not have the training required to deal with this high level of trauma, so I went and got more training. Any of you have ever had an imposter syndrome? Where someone's seeing you, maybe they've even waited months to consult with you, and they're asking you these things, and you're thinking to yourself, you should really see someone about that. And you realize it's you, right? I had that all the time, so I went and got more training. Finally, with my military, I had referral resources. I had places to send them. It wasn't perfect, but we had Blue Cross. I had 12 sessions with them. I felt great. So it's not always about the trauma and the stories. It's about your working conditions. Does that make sense? Yeah? Okay. So I did a TED Talk. Wow, pretty much the same outfit. I have 2, so try to rotate them. I did a TEDx talk a year ago at Queen's, and if you have friends who were not able to come to this, it's just 17 minutes, as you know, and it talks about the basics of what is compassion fatigue, what does it look like, and I give lots of case examples, so if you want to watch that or refer it, it's on the website, it's easy to find. So I've kind of talked already about this, so I'm going to skip a few things, but basically compassion fatigue refers to this deep erosion. It's like this emotional and physical exhaustion. I actually like to call it empathic strain more because the Buddhists got all mad at us. They're like, you can't run out of compassion, just like you can't run out of love. Any of you have children in your lives and there was a new one added, you're like, sorry, I'm all out. Like I gave all my love to these 2. So they're like, you can't run out of compassion, but we can definitely have empathic strain. And you've probably also seen it in some of the families you work with. And, elder care, really burnt out, family caregivers. And that can happen at home and in our personal and professional lives. And it happens especially with our frequent flyer, very challenging, hard to treat folks. Any of you work in diabetes management? Talk to people in diabetes education. Anybody's ever been to physiotherapy? Raise your hand. You've been to physio? Did they give you exercises? Did you do them? Yeah. Do you know how sick physios are of that? Like you don't do them and you come back, you're like, and you're like, did you do them? No. They're like, yeah, I got nothing now. Non-compliance, right? So here's a quick example of what secondary or vicarious trauma looks like. We use these terms interchangeably. And when I have more time, we workshop this, but I'll show you a couple of quick examples. I'm going to show you a picture now. And I'm going to invite you to turn to your person sitting next to you. Don't question this, just what is your automatic thought? You ready? Turn to the person next to you. What do you see? What's your reaction? Go for it. Okay, you ready for the second one? Your face. Okay. How many people saw the first one and thought, freedom and wind in my hair? How many people thought donor cycle? All right, second one. How many thought loss of pelvic floor control? No, that's for physios. How many people thought fun, I want one, I have one? How many people thought orthopedic injuries waiting to happen? Okay, so basically our view of the world is transformed by our own lived experiences, but also the work we do. And when you show this to a complete group of civilians, they never think donor cycle, they never think orthopedic injury, they just, right? So it's a really quick way to show this. So the final example I'll give you about this is how it affects, if you have children in your lives, how this work affects your parenting. So because I'm a trauma specialist, I've seen and heard more things than you can imagine, and I'm sure you can imagine. When my son was 7, he wasn't a strong swimmer, and he was going to a summer camp, you know, run by bored teenagers, like a YMCA camp, yeah? And I heard they were going to Picton for a day, a swim day. And I get to the park where the sweaty, hot school bus is going to take them there. And I talk to the terrified 15-year-old camp instructor, and I say, listen, Jason. I said, life jacket on my son. Am I making myself clear? He said, yes, ma'am. So I pick up my son at the end of the day, and he gets off the sweaty school bus in the life jacket. And he says, thanks a lot, Mom. Right? This is a text exchange I had with my daughter. She was 16, very trustworthy kid. She'd been left alone for the weekend, maybe even 17. And it's Saturday afternoon, so you're just doing the quick check. You've ever done that? Like, hey, what's going on? So here it goes. I say, hey, Naomi, what are you up to? And this is her answer. Yeah. It's totally great. All right. I want to go back to system failures because I think, as I said before, that actually it's the #1 contributor to burnout in our context. And the real scientific term for it is moral distress. And some of you are familiar with this. Every hospital has or should have a medical ethicist that we call when we have really complex dilemmas. Who should get this organ transplant? What do we do about a family who does not want blood transfusions because of medical or religious reason? You're familiar with all those, right? And moral distress, and a lot of work on moral distress was done by Françoise Baylis from Ottawa. And she talks about moral distress comes when there are inconsistencies between your beliefs and what you are mandated to do. We have so many examples that we could give, regardless of your personal opinions or convictions. Early discharge to nothing. How many of you have had that? Right? No funding, eligibility, resources. In the criminal justice system, we talk about aging out, like they're the crown wards, and then they turn a certain age. We're like, good luck, little buddy. Imagine working in healthcare, and maybe some of you have, in the United States right now. You've heard about the insulin issue, where people can't afford it, so they die. And if you watch the Mayo Clinic documentary, you'll see at some point that there's a patient who's been diagnosed with leukemia. They're treating her. Her husband loses his job and therefore his benefits, and they discontinue her treatment. So whenever you're frustrated about Canada, just think, you could be working in America. But it is a huge source of frustration and distress, and the thing that's hard about moral distress is sometimes there is no solution. Sometimes the solution is quitting. Right? There are times where you're like, ethically, I'm done. But what we don't do a lot of is social support, where we can turn to someone and say, I am not okay with this. So if you're interested in more of that, I co-wrote a chapter on this with Leslie McLean. And it comes out of University of Pennsylvania. It's called Person-Centered Care. I'll give you the slides at the end, by the way, if you want them. And we talk about moral distress and compassion fatigue in the hospital environment. Now, some of you know this. In fact, probably most of you know. What is the best way? Let's say there's been a medical error. What is the recommended way that has been found to be effective to reduce the chances of lawsuits? Right. Apologize and tell the truth, which is exactly what the lawyers would tell you not to do, right? It has dramatically reduced the chances of people suing you, because they don't want to sue you. They just want you to tell them the truth. So we have a good conversation in there about how does moral distress lead to breakdown in communication, and flipping that around, how we can resolve it. All right, if you have questions, save them, because I'll definitely want to see if anyone has questions at the end. All right, so this is me. And I had kind of this crisis a month ago. I was like, I have given talks to 100,000 people now. And I thought to myself, surely to goodness, no one needs this talk anymore. And I was like, doesn't everyone know how to be well? And then I went back to the literature. How long have we known that this is a good thing? Anybody know how long the data has been there to prove that this is a really great way to reduce the spread of infection in hospitals? It wasn't Florence Nightingale before that. Anybody know? I found the research paper because I'm a nerd, so it was 1846. Do you want to see the paper? I can't say that. It says, preventing the transmission of I'm French, I don't know, the fever that transmits when your hands are dirty and you give birth and you deliver a baby. I can't do it. Can anybody say pural? Yeah, that. Anyway, so I'll work on that. The transmission of fever, women die in childbirth. You all with me? Yes. We've known about this since 1846. How often do we do it? So some of you know about this, especially if you're an epi. Another word I can't say, so I say epi. The CDC did a study in 2016, and I'm not picking on you physicians, but it was you that were being observed. When they knew a nurse was watching, they were 47% likely to wash their hands. When they thought no one was watching, or just like they had basically planted like people that look like minions, like of no importance, but they're actually secretly observing, 22% likely to wash your hands only. Right? So, folks, how many people in the room do not know that washing our hands prevents the spread of infection? No. So that revived my faith that although everyone in this room knows about self-care, doesn't mean we don't need to re-look at what's going on and what are the obstacles for us doing it. Now, I hope you have all read the wonderful Dr. Atul Gawande. These books are phenomenal. I've read all 4 or 5 of his books. He's an endocrinological surgeon from Ohio, and he is a New York Times bestseller. How many of you have read his books? Phenomenal. I particularly want to invite you to consider these 2 books. The Checklist Manifesto came out of him. If you've ever been on a flight and a tiny plane and the doors open, you hear them go through a checklist every single time they fly. They created these checklists to make sure that we missed nothing. And Atul Gawande was interested, and he worked with the World Health Organization. He wanted to create a checklist that some of you probably use so that we would prevent complications, prophylaxis, for example, of antibiotics. How do we make sure that we follow the checklist in a surgical room to make sure that we prevent the spread of preventable things in the OR? He did a test. There was a hospital in India. There was one in England. So he vetted the list, and at first people said the list is too long. We're not going to do it all. And this book talks about this process. It's fantastic. Would you agree? I mean, he's a wonderful thinker. And the book Complications is great too, A Surgeon's Notes. And I like his vulnerability, his brilliance, and his honesty. So I recommend that as a wonderful resource. His book that he just wrote, which I forget the title of, is about his father, who was also a surgeon, by the end of his life, and how it's altered the way that he looks at end-of-life care. So recommend them. All right. So why are our workplaces so different than working in an accounting office or a gaming office? We were recently called by a very large gaming company. They produce like some of the biggest video games that some of you or your kids know about. And they wanted help with their video game editors. I don't know if you know this, gamers have one of the highest rates of depression. Well, think about it, right? Like you're 22, you live in your mother's basement. Well, no, I'm profiling, but My nephew is a professional gamer. Like he basically earns a living by playing on YouTube. I don't understand it, but he has high rates of depression. So this company wanted us to help with stress. But they don't work in a trauma-exposed environment. It's a stressful environment. So there's something very unique about our work environments, and I'm going to give you a case example of something that happened in another hospital recently. All right, are y'all ready for this? This is a true story, unlike all the lies I've told you already. Okay. So their kettle in this unit, it broke. The kettle broke, y'all. And you know what happened then? They had to create a committee to vote on the replacement kettle. And the new kettle arrived, and it was different. And people were very upset about this. Then we had a collection, like I'm going to grab the $2 per person. And some people were like, I do not consume hot drinks. I'm not giving my $2. Some people started a rumor that the new kettle did not boil as hot as the old one. Any of you have seen this in your workplaces? Right? We call it sweating the small stuff. Understanding. Oh, and by the way, my brother, who works at Cirque du Soleil, he has never encountered that, ever. They have 50 kettles if they want, right? Is that a code? Do I have to stop? No, we're good? Okay.
Code medical, exterior, south entrance. Code medical, exterior, south entrance. Code medical, exterior, south entrance.
I'm well trained, right? So my brother at Cirque du Soleil has never encountered this. They have other stresses, but they do not work in a trauma-exposed environment, except when once in a while something goes terribly wrong and it's completely outside their wheelhouse. You still with me? So my co-executive director, Dr. Patricia Fisher, who's a clinical psychologist with years of experience in the field of trauma, became really interested in this. And that's actually how we met over 15 years ago. She was like, it turns out that the really expensive organizational health strategies that might work to make Toyota work better don't necessarily work as well in our environments. And why is that? So this is the model she developed. I'm going to present it to you real quick because to me, it changes everything about how we think about our work environment and what we can do. It's called the complex stress model. So if you look at the systemic workplace stress, can we agree that the blue stuff could happen anywhere? Could happen at the Goodyear tire plant, could happen in a hospital, right? We have job stress, we have harassment sometimes, friction, conflict, and we have burnout. Here's the thing. The trauma piece, it doesn't matter whether you have a high trauma job or not, it's in the ventilation system. You ask your clerks, you ask your caretakers, you ask your anyone who works in the service part of this hospital, whether it's the same to be a cleaner here as it would be in a real estate office. You ask them whether it's the same. It's not the same. And also your janitorial staff are the first line of defense against major infections sometimes. And they don't get recognition in some hospitals, and other places they get lots of recognition. So traumatic exposure is called a synergistic effect. Now you all know about synergistic effects, right? You combine two things, it amplifies them. What are you not supposed to take with grapefruit juice? What medication? Statins, right? So there's certain things that when they're combined, they amplify or interfere with the absorption of the medication. I hope you all knew that, right? It's okay. You're like, I'm a surgeon, I don't need to know that stuff. A synergistic effect is when you combine two things and it amplifies the reaction. So it turns out that in your environment, sometimes people overreact to things that seem incredibly minor if you're in a leadership role. Have you ever announced good news and been met with hostility and cynicism? Right? They're like, that was not the plan. There's change. Our welfare system in Ontario, called Ontario Works, brought a new computer system a few years ago. It's called SAMS, and it was a hot mess. It was a hot mess. It didn't work well. Literally, people quit. People who'd worked there for years, they were confident, they were competent, and the new system.
Medical, all clear.
All clear.
Medical, all clear. Medical, all clear.
I recently presented in San Diego in what looks like an airplane hangar, and it was right next to the airport, and I had to stop every 3 minutes. It's amazing. Okay, the other strategy that we start seeing in hospitals, we have called the must be nice phenomena. Now, I love nurses, so I'm not about to trash nurses, but nurses in the room, would you agree that the saying is, nurses eat their, oh, see, universal. Nurses eat their young. And new nurses come in, you're like, right? And then they get upset and you're like, suck it up, buttercup, can't take the heat, get out of the kitchen. And I don't know why I imitate nurse having a voice like that, but We see a lot of horizontal violence among nurses. And I could, if I had more time, I'd explain to you why I think that is. I have some thoughts about when we are actually in female-dominated profession with low power and low agency, we turn on each other, right? And so we start seeing this thing, it's called the must be nice phenomena, and it's a strategy I'm going to offer you. And I really believe that in order to understand the professional, we need to understand the personal. So we're going to try this and see if it works for you. Have you ever had a friend who started taking really good care of themselves and they kept at it? I don't mean like some New Year's resolution. I mean they kept at, like they start power walking at lunch. And now it's July and they've been doing it for 6 months and they've lost weight, they look amazing. And instead of being like, you go, you're like, must be nice. Must be nice to have that kind of time. Have you ever had that experience? What is the underlying emotion? What's the underlying emotion? Yeah, envy. I like the word envy. Jealousy, I like it too, but maybe envy. How about we call it longing? Or guilt? I have a colleague, or she's a colleague of my husband's, and she's a very social media person. You know what I'm talking about? And she always talks about her fabulous life and her great parenting, and she does like science experiments with her kids for fun on the weekends. Yeah. And I start having like evil thoughts about her. I'd be like, oh, good for you, Meredith, like, you know. And it turns out what that is a reflection of is my guilt about not being that kind of mom. Like I would take a vacuum cleaner while my kids baked to clean the flour. Do you know what I mean? Like they'd come home from daycare and they'd say, can we paint? And I was like, didn't you do that at daycare? Like, why mess, you know? So the must be nice reaction is actually a very powerful tool to examine what we crave, what we long for. Any of you in the room never want to do hot yoga? You're like, that is disgusting. I'm never doing that. Anybody never want to do hot yoga? Right. You're like. So in fact, if someone else told you they do hot yoga 4 times a week, I think your reaction would probably be, knock yourself out, right? The thing that really gives you good data about how you're doing, and joking aside, this is really robust. We've tried it for 15 years. Go out into the world and see what's pissing you off about other people's self-care, and what's making you angry is what you yearn and what you crave. Now, let's bring it to the workplace. When we don't have enough resources, Linda Duxbury has called it a poverty mentality due to role overload. Does that describe most of your jobs, right? We have role overload, we have too much to do, not enough time, and so what happens is we turn on each other instead of banding together, and ironically, you know what the research showed? You know the best protective factor in high-stress, trauma-exposed environments is social support. But that's not what happens. We start having these like, must be nice to call in sick on a long weekend. Must be nice to come in 15 minutes late from your lunch, right? Because we are all maxed out. And instead of supporting one another, we turn on each other. And we see workplace bullying and all these conflict that arises. So this is the model that we use. And when we do an assessment with an organization, we have an online metric where we assess every element that's going on. So we basically give a score of how your folks are doing in every one of these elements. But what we started finding is that we need to start with the foundation elements. Have you ever been to a company picnic, Christmas thing, and everyone spent the whole time griping and talking about work? We call it, I have a friend who's a nurse, she calls it BMW, bitching, moaning, and whining. Right, where we gripe, or we have a post-meeting vent with our friends. So it turns out, well, let me give you another example. Have you ever tried to have creative process, like a mission vision retreat, and everyone was on their phones and practically like vibrating because there's nothing coming out of that meeting, right? Do you think at Google, why do you think Google has like aquariums and hammocks and slides and stuff for their staff? Do you think it's because they like them? No, it fosters creativity. They have room and capacity to think about it. So what we started getting phone calls from organizations who said to us, why are people not coming to our mindfulness lunch and learns, which I believe in? And this was a children's courthouse. And it's a long story in America. It's crazy. They have something called baby court. Never mind. It's not the baby that's like in the docket. It's baby court. Who does that? And they call me and they say, why are staff not coming to our mindfulness lunch and learn? And I said to the director respectfully, are your courtrooms running at lunch? And she goes, yes. Why? Well, I said, how are they going to come? They're in court. And she's like, oh shit, you know? Here's what we also found out. It's wonderful to have a healthy working environment and spaces for people to be, natural light, fireplace, like all of those things make a difference. But you know what staff have all said they want more than anything as it pertains to self-care? They want control over their schedule, right? So Linda Duxbury, again, Canadian research, did a study of healthcare organization in Ontario and compared it to the national Joe Canadian worker. Joe Canada, 25% of them said they'd rather have more control over their schedule and less money. But 3/4 of them said, no, I want the money. In healthcare, 4 out of 5 of you said, more control. I don't care about the money so much. More control over my schedule. So if we look quickly at the foundation factors, these are critical and they are mutually interactive. Leaders are people too. And many of you are dealing with stress effects. We recently were working with Behavioral Services Ontario. You're familiar with BSO? And this is what happened. HQO, you're familiar with Health Quality Ontario? Okay, HQO realized that the rate of violence in long-term care facilities in Ontario is going through the roof. We have a lot younger dementia patients. Imagine it's not 97-year-old Agnes with dementia, it's 52-year-old guy who used to be a hockey player. You know what I'm talking about? Things have changed. And so the nursing homes, long story short, HQO said you need more money for behavioral management in psychogeriatric care. They gave BSO $10 million. Does that sound like a great news story? Sounds amazing to me. They start rolling it out, and they discovered 2 things real quick. Most people who learn to be behaviorists in this province learn to manage kids with autism. We have a huge lack of psychogeriatricians. So in fact, they had no staff to hire. And secondly, what happened is the directors of the nursing homes, we forgot to check with them whether they had the capacity to roll out $10 million of what was going to be amazing. And a lot of directors of nursing homes, you know what they do? They do a lateral move. Like they're burnt out, so they move to another nursing home. So they're crispy fried. And they were the first group to push back. They're like, no new ideas, right? We're done. Leaders are people too. If you're a leader, you are a powerful role model. People are watching. People are watching what you say and what you do. Number 2, succession planning. We have lots of generations right now in the workplace. And I hear all these things. I want to disclose to you right now that I'm a Gen Xer, but I'm really a millennial trapped in a Gen X body. Like I think the millennials are the secret to our survival. For real. I know some people roll their eyes. They're like, what do you mean you're retiring at 25 and going on a spirit quest to the hills of Scotland? Do your job, you know? But we're seeing a lot of multi-generational friction. Would you agree with that? There's friction about priorities, about values, about technology, about people's choices and priorities. I have a millennial who works for me. She's amazing. She does all our social media and technology stuff. And we recently had a computer website issue. So she's working on it. And then I see her look at her watch and she goes, well, that's me done for the day. And then I look at her and she's like, gotta go catch my bus. And I'm like, okay, right? She values work-life balance more than anything else. Where do you think kids learn that? Because they were raised by us. I don't know who raised you. I certainly know that I'm a Gen X. My parents were from the war generation, right? Born in the early 40s. Work-life balance, you worked till you died, and then you worked harder, right? My father, who was a school superintendent, used to have 2 rum and cokes after work, this much rum, this much coke, smoke a pack of Export a day. My mother ate till she passed out, right? She exercised once in 1973, I'll never forget it. She woke up the next day, she had micro tears, but she thought she was dying. My mother, of course, developed type 2 diabetes, had to have an emergency double bypass 2 years ago. She got MRSA, and she was in the hospital for 4 months, right? My father has COPD and emphysema. None of this surprises me, right? Or you. What are the messages you received? If you want a phenomenal free resource, although it's 9 years old, it has withstood the test of time. If you're in management dealing with millennials, go to the Conference Board of Canada and get this report called Winning the Generation Wars. And to give it away real quick, in the interest of time, what they conclude is that generational friction has been around since time immemorial. In 63 AD, Cicero was like young kids these days, you know? And if you're having frustration with generational stuff, I also want to invite you to think about what were you like at 21? And are you the same person? Some of this is developmental, right? 21 is not the same as 42. You have different priorities and values, and the more we understand each other, the better we're going to be off. All right, so then what we do when we assess an organization is we assess what we call the functional capacity of a workplace. So the functional capacity is, how are your leaders? What's going on with, oh, sorry, I forgot something. Succession planning also refers to attracting good people, but also keeping them. And dealing with natural attrition of your boomers who are imminently in the process of retiring. What happens when you lose all your institutional memory? Would you agree that there are some people, you have a retirement clock and a party scheduled? Like when they leave, you'll be like, don't let the door hit you on the back. But would you also agree that we are going to lose mentors? Yeah. Right? Elders, you know, people who are a treasure trove of wisdom and mentoring. That's happening. And we have the biggest demographic shift. Compared to the US, we have a bigger pool of boomers than anywhere else. Right? So this is happening. So the way we do this, it's called assessing the functional capacity of a workplace. And what we do is we basically look at what is your leadership stress level, what's going on in terms of your succession planning, what's going on with your employee health and wellness, and I want to add one more piece before I show you this chart. Many of you know this already, but it takes a minimum of 2 years to be reasonably competent at a job. Does that seem fair? Those of you in leadership roles, what kind of training did you get to become a leader? Would you agree most of us were thrown at the deep end of the pool and said, swim, swim, right? Any of you were promoted within your own agency, so now you are actually overseeing your former colleagues, right? So let's take a real quick look at this, and I want to invite you to think about your division or your unit and see what is the functional capacity of your workplace. So let's pretend that you have a staff of 10, and you have 8 experienced staff, and they're running on full cylinders or running at 100%. So that gives you 80% functional capacity. And you have 2 people who have under a year of experience, so it's reasonable to give them 50% capacity. Your workplace is running at 90%. Good for you. Let's look at scenario number 2. You have 4 experienced people, 4 who have under a year, and 2 who have under 2 years, so you're at 74%. Pretty great. Scenario number 3. You have 4 experienced people, they're a little stressed. You have 1 on sick leave, so she gets a big fat 0. You have 3 who are struggling, they get 60%. You have 1 who has under a year, so that's okay. And you have 1 under a year of experience, but she's also struggling. She's at 30% capacity. Your functional capacity has dropped to 58%. You ready for the last one? 2 experienced. 1 on sick leave, 1 struggling, 3 under a year, 1 under a year and struggling, 2 under 2 years and struggling. Your functional capacity has dropped from 90% to 50%. Folks, this is not just about having bums on seats. It's not just saying, well, my metrics are looking great. I don't have anyone on sick leave right now. It's also about who is coming to work and what shape are they in. I recently worked with the prosecutor's service, so this is 100 crowns. And the year before, we had done a training for them, and they had made my associate cry. Who makes people cry in a training? Maybe you're going to make me cry. I don't know. They made her cry. It was a very toxic work environment. I meet the leader the night before at a dinner, and he says to me, I don't know why we're doing this self-indulgent, touchy-feely topic. I don't have anyone on leave right now. And I say to him, respectfully, sir, I'm thinking that the functional capacity of your staff is actually quite low, and here is why I think that. His neck started bulging, His veins started popping. He turned bright red, and I thought, oh, you're the problem. And he was, right? And so leadership matters, succession planning, respecting and helping people at various stages of their career, dealing with natural attrition, attracting good people and keeping them, and looking at employee health and wellness, which is exactly where self-care, wellness, control over our schedule fits in. Are you all still with me? We're good? Okay. So the other thing I get a lot, especially from surgeons and from child abuse investigators, I also work with people who investigate, so let's say like for the FBI, they investigate child pornography. You get the idea? And they all say to me, I need this armor, right? I feel nothing and it's working just fine for me. So I wanted to go back to the literature and I asked basically my colleagues the question, should we actively seek to turn off our emotions when working with difficult cases? Right? Is that actually a really good idea? And the research actually says not so fast. So I went back to the literature and looked at two groups. Don't be offended by the titles. This is not me. It's the researchers. They call these jobs dirty work. And there's research on what's called necessary evils, which is something many of you have to do. So let me talk about what the research found. So necessary evils are tasks in which basically you must knowingly inflict harm in order for greater good. So putting an IV in, right? My daughter, when she was 3, had to have a VCUG. If you know what it is, right? It's a urethra, like it's a catheter, and they die. Like and you knew it was going to be bad because as I walk in, the radiologist is already giving her stickers before the procedure. You're like, this is bad, you know. So there are times like that where we know that we need to inflict harm for the greater good. And so obviously inflicting pain on a patient. What about performing evictions? Layoffs. My brother once had to fly to Macau and fire 400 people in a day. He's so good at it, though, they thanked him. For real, he is that awesome. Death notifications in law enforcement and also delivering difficult diagnoses. Can we agree that some of you in this room are really good at that and some of you are not? Right? And we know that when you receive bad news, you remember that for the rest of your life, how it's done. I've talked to enough victims, parents of murdered children to tell you that although the news was awful, they remember how you did it for the rest of their lives. Duty to report, does that make sense? Necessary evils, right? And the studies of dirty work looked at people that do work that is perceived as unpleasant or disturbing to the wider public. Pest control, I think we could all agree. Corrections is part of the list, probation, collection agencies, ER nurses, sorry, you're in there, I don't think your job is dirty. Funeral directors, internal affairs, so if you work for the SIU and the police, who would not want to work for the Toronto Police right now? You guys. Social workers, personal injury lawyers, right? So what I wanted to know is people who did this research, what were found to be protective factors, and I want to share that with you. A lot of us, what we do is we reframe. We're like, well, someone's got to do it, might as well be me. Social buffers, going to a convention, hanging out with people who do this job so we can talk about it in a way that the common public might not think is interesting. Have you ever told a joke to a group of civilian friends and it was not funny? You're like, come on, this is hilarious. I had friends over for dinner this weekend. She's a teacher and he's a neuroscientist. My husband's a neuroscientist. He studies how you grab stuff and move it. That's what he does. And I had just come back from a big child abuse conference, and finally the friend Marianne said to me, could we talk about a little less about child abuse over dinner? And I was like, oh, why? It's fascinating, right? So sometimes we talk to our people using dark humor. I'm sure you've never done that. We also have strategies to avoid talking about what we do with civilians. Any of you have ever gone to a party and someone showed you their rash? Right? So I know, and maybe you do too, I know a lot of people who have fake jobs, like they lie about what they do for a living. Yeah? Oh, I'd so like to talk to you after. So people will say, I'm a Walmart greeter. I work for the government, or something equally benign. Social comparison. We know we have this. I know physicians have a hierarchy. Did you know in the trades, for example, there's a hierarchy? Anybody know in the trades, construction and stuff, what is the lowest trade, the one that's considered the bottom by all the tradesmen? No, I'm talking about construction. In construction, roofers. Roofers are at the bottom, even though they're at the top, get it? Right? Right? And electricians are at the top. And we know, we're not going to do that here, but we all know that you all have a classification of who are the cooler docs and surgeons, right? And we're not going to talk about urology and where it belongs. But what we do is we do social comparison. So I work with law enforcement a lot, and a lot of paramedics, I was working with Frontenac paramedics recently, and they're like, why doesn't everyone like us? We're cool. Why does everyone like firefighters? What's so great about them? We're hot. I was like, well, no, you're not. But that's what we do, and there's rivalry and friction. But think about this, joking aside, how that actually creates factions and divides us when we should actually be working together for the greater good. Distancing from our clients, blaming our patients, we do this all the time. And what I'm going to share with you, can I go over by 5 minutes and then, yeah, sorry, do what I want? Okay.
You're okay, because it just shortens the Q&A.
Is that okay? Do you guys want me to keep going or stop and have questions? Keep going? Okay, so what I'm going to do, if it's okay, is I'm going to go on for 10 minutes and then we'll take questions. So here are the findings. The findings are that being authentic and creative in difficult work is actually a protective factor, not a vulnerability factor. Let me give you some examples. So I'll give you two. One of them is called customized acts of interpersonal sensitivity, and I'm going to give you a salient example that I heard 2 weeks ago. So we have a strategy that we developed. I'll show it to you now. It's called low impact debriefing. And I brought some of these cards, actually. They're in my suitcase if you're interested in them. And there are 4 steps on how to share difficult information without re-traumatizing someone else. You still with me? So this is a strategy we've developed. We promote it because it's a very easy tool. And I have a colleague who said to me the other day, she said, my sister is an OPP officer. And I taught her the low-impact debriefing strategies, and she has become the top death notification OPP officer in her region. She does it so well that she feels good. The people, of course it's a terrible news, but she literally has become the lead trainer for OPP about how to do it in a way that is compassionate, and because she's doing it well, she is at less risk of burning out. Does that make sense? It's fantastic. So I have these cards, just remind me, I'll take them out. And I'll give you my email at the end. We can send you all of these. This is on our website too. What also works is being able to provide resources and supports within limit, even when they actually conflict with the mandated rules and protocols. I'm going to give you an example. If you haven't seen this Netflix show, I encourage you to watch it. Anyone has seen Heroin? It's a 30-minute documentary. It's fantastic, right? So I'm going to tell you a crazy story in a minute. If you don't know what it is, it's in West Virginia, the heartland of the opioid epidemic. And these 3 women have become these fantastic advocates. So there's in particular Judge Patricia Keller and Fire Chief Jan Rader, and a third person who does outreach. She gives safety packs to prostitutes. And what's so incredible about them is that they're providing compassionate care. Judge Keller is a drug court judge. Fire Chief does Narcan. And this is where in the documentary you'll see this really interesting moment of friction. I'm sure if you've worked in ER or if you work with paramedics, there is a real compassion fatigue around opioid overdoses. Can we agree with that? Right? And there are times where you have to give naloxone or Narcan 15 times in a row to get people back. So Chief Rader has some paramedics in the documentary who say to her, what a waste of resources. They're like, what do you mean? Do I have to do this? And he goes, it took 25 doses. When do I stop? She goes, you stop when they come back or they're dead. And she is having to go through West Virginia trying to convince people that this matters, because she said, I believe that this could be your chance to actually get clean. And I want you, if you watch it, to watch Judge Keller, how she works with her drug patients or her drug offenders. She is firm, she is tough, she is compassionate, she is kind. That woman's not at risk of burning out. So it's a really great example of doing a tough job, but doing it well with compassion, and their compassion is protecting them, not causing them to burn out. So the crazy story I was going to tell you is I showed this last week in Huntsville, Alabama, and someone came to me at the end and he goes, they're my two best friends, and here's their number. They can't believe you're talking about them, so I got to call Judge Keller tomorrow. Crazy. I want to go and ride along, don't you? I have the best job ever. Okay. A couple of last things I want to talk about, and then we can have a conversation, is that I'm concerned, even now, about the level of stigma around mental health and burnout in healthcare. I was a therapist in private practice for 15 years. I saw everyone. I saw judges and chaplains and pharmacists and physicians and nurses and dentists and the women they're all sleeping with. Like, I knew everyone's business, right? And I realized that stigma is such an obstacle where people are afraid. And the example I want to give you of someone who told everyone for years that he was immune, that he was invincible, and it turned out he wasn't, is someone some of you probably know, and that's Dr. John Bradford. Dr. Bradford is a top forensic psychiatrist in Canada. He was involved in the Picton case, Paul Bernardo case, you name it, he was there. Russell Williams case, on and on and on. You understand what he does? 30 years of sexually motivated crimes, expert witness, looking at all the evidence, the video, you get it? And he's my friend's boss. And up until the Russell Williams case, he said to everyone he was immune and PTSD was bullshit. And then the Russell Williams case happened. And I don't want to go into it, but what he discovered later, because he almost ended his life, and he openly talks about this. This is on the National. He now belongs to a judicial resilience panel. And he said, you know what? I think what tipped it over the edge was wear and tear. So he was doing the Russell Williams stuff on top of his job, driving 2 hours a night, then coming home and watching 48 hours of high-definition crime video that Russell Williams had filmed. So it was an accumulation of 30 years, wear and tear. So he wasn't sleeping well, he was drinking too much. And then he started falling apart. And then he told no one. He said, who's the top forensic psychiatrist in Canada supposed to go to for help? And for a year he tried to help himself, and finally he realized that he was going to die. And he finally came out and talked about this. This isn't about other people, folks. This is about us. And I'm so grateful to him for that. So what can we do? So let me wrap this up. Essential tools for best practice. Number one, monitor what's happening to you. We have a very robust measure we've used for 17 years. It's super simple. We call them the warning signs. How do you know you're in the yellow zone? Physically, emotionally, behaviorally. Maybe these are your favorite things. They're all legal. It's none of my business, right? But if it's a daily practice, here's the difference. You know the difference between watching your favorite show on Netflix and having the sign that comes up that says, are you still there? Right? We know that a lot of us are abusing substances. We don't talk about that. Some of you don't drink or do drugs, but you eat till you pass out. If you work shift nights, I don't know about you, but at 3 o'clock in the morning, I have never craved broccoli. I crave sugar, salt, and fat, right? Workaholism is one we never talk about. Workaholism is a way of masking the fact, and we are indispensable. This comes out of a Department of Child Family Services in Florida, where they said to me they were getting sand in their smartphones. And I said, why? And they're like, well, I take it to the beach. And I said, why are you taking your work phone to the beach? And they said, we are on call 24/7, 7 days a week. Florida has the second highest rate of child abuse-related deaths in the country, right? And they've had to make some changes. So what does that look like for you? Number two, get more training. I can't say this enough. In fact, this saved my career. Understand non-compliance. What does that mean? Why are folks not complying? And if you're not familiar with the Adverse Childhood Experiences Study, this is your homework, even though I'll never see you again. Go and watch this TED Talk by pediatrician Dr. Nadine Burke-Harris, who is now the Surgeon General of the state of California. Watch this TED Talk where she explains, she worked in a lower impoverished part of San Francisco, and she was like, why are all these kids being asked to be medicated for ADHD? What's wrong with this community? What's going on? And she finally realized they had 4 or more crappy things happen to them before the age of 18. And we know that 4 or more adverse childhood experiences lead to a dramatic shift in people's immune system, ability to metabolize medication, increased rates of obesity. So I want you to think right now of your most irritating patient where you see their name on your roster and you're like, ugh. What are the odds they have 4 or more crappy things that happen to them before the age of 18? So if you're not familiar with that, this is it. What works? Social support. We talked about this before. There was a study done at York University that found that what made the biggest changes were organizational changes, better working conditions, more control over your schedule, better supervision, so on and so forth. So I'm going to move on because I only have 2 more minutes. So I just want to go to the last bits here, and then happy to take questions. Again, if you want these, we will email them to you, happily. All right, so here we go. Last few slides. So we work a lot in First Nations communities, and we were working in a women's shelter, and this woman said to us, what is the recommended dose of self-care? I think she wanted to go home and tell her spouse, she said 45 minutes, that lady said, right? So she said, how often should I take care of myself? And we thought about this, and I actually wrote a blog post about it if you're interested, that called Breathe, Reset, Refuel, Rinse, and Repeat. It turns out, folks, that white-knuckling it through your day and then collapsing on your yoga mat at the end of the day doesn't do very much, right? Self-awareness is actually more of a moment-by-moment process. So the final piece of research I'll share with you is called career-sustaining behaviors. And career-sustaining behaviors are, what are things that actually allow you to feel well and healthy? And what they found is the following. Number 1, have a life outside of work. Don't volunteer at the Kingston Penitentiary as a hobby, right? Have confidence and competence, finding the work interesting, creative, intellectually challenging. Those things make the biggest difference. Liking your job. I'm a huge believer in quitting your job, which I know is not a popular thing when I talk to leadership. They're like, don't say that. But there are times where it's time to go grasshopper, right? And I'm not saying you're going to quit your job and go and make a living selling earrings, because you're not. Don't do that. That's not. You know the book, Do What You Love, the Money Will Follow? No, it won't. It won't. That's not true. But there are times where it is time to go. So I want to finish with this piece on equanimity. Equanimity means that you have ups and downs and highs and lows, but you can return to baseline really quickly. This is why mindfulness works, by the way. Mindfulness allows us to return to baseline quickly. There's lots of research on expert meditators, and it demonstrates that they're really good at that. They can return to baseline. This is a slide that was given to me by the LAPD, because a lot of people are like, well, I'm never doing that. It doesn't have to be 40 minutes, 3 minutes, using those great new apps that they have, all of that stuff. So there's lots of cool stuff out there in terms of research and strategies. Again, if you want these, I'll send you the slides. We wrote a special issue of a journal on this topic. There's a free organizational health assessment you can access. Just grab all that stuff from us. And I want to conclude by using Stephen Covey's very popular circles of control and influence. Cheryl Richardson, who wrote a great book years ago, said, do not confuse difficult choices with no choice. I go to so many organizations where people will say to me, it's so bad here, you have no idea, And I'm like, I have a pretty good idea. Respectfully, I do. But I also got worried, to come full circle to the beginning of my talk, I became worried that some staff were using their anger with their workplace to deliver sub-quality care, and I'm not okay with that. So if people are delivering substandard care, it is time ethically to leave. Or it is time to make decisions about what we control and what we don't control. So when I worked at Queen's, I controlled a lot about my personal environment. I also controlled what I could influence and the attitude I brought. And I decided to stop bitching about work after every staff meeting, because that was more like a fake workout. Have you ever done a fake workout? Watched the CrossFit games while eating chips? My colleague and I decided to stop complaining about work. Advocate for change, yes. BMWs, no more. And it dramatically increased the quality of our work. So I have a friend who's a physician, and she told me that physicians like a concluding slide that says what we talked about. So there it is. That's for you. A member of our think tank, actually several members, Dr. Ginny Sprang and others, have created a free organizational assessment. It's called the Secondary Traumatic Stress Informed Assessment. And I'll provide you the information. Basically, it was designed for you to create a roadmap on how to assess how you're doing right now and where to begin. And if you actually want it to be electronically scored, then she'll collect the data, it's confidential, and she'll give you a report about where to begin, where are your areas of strengths and where are the areas of weaknesses. So that's my recommendation, is to look at that assessment to decide where to start. Now, I like to say dig where the ground is soft. Dig where the ground is soft. Work with, as many of you remember from the tipping point, you only need 10% of people on board to create societal or group change in an agency. So that's what I would recommend. And I would also recommend Dr. Fisher's book, the one at the beginning, Building Resilient Teams. Louisa, you probably have it, right? So just borrow it from her. If you don't want to purchase it, because I'm not trying to sell you anything. But we have found that these two books by Dr. Fisher have been wonderful resources. The orange one is for leaders. They're workbooks, so full of strategies and worksheets. Resilience, Balance, and Meaning is for individuals to assess your level of stress effects. They talk about the window of tolerance, hyperarousal. So to me, they're fantastic tools. They're very inexpensive, and they're not mine, so I don't feel like I'm in a conflict of interest talking about them.